And the article shared for today, so it's a peer-reviewed article with case and commentary. When experiencing inequitable healthcare is a patient's norm, how should iatrogenic harm be considered? So the case is of ST, so that's the patient's name, or what we will call the patient in this case. So it's a 45-year-old woman with a long-standing history of schizophrenia and violence. Occasionally, she does respond appropriately to clinician questions, but she's been hospitalized in several organizations a number of times for swallowing sharp objects, which ultimately requires surgical removal, for which she typically objects to with fear and anxiety. That fear and anxiety is so great that she must be forcibly anesthetized. So she's experienced several episodes of physical, chemical, and legal restraint during her encounters with clinicians. She's traditionally not kept post-hospitalization follow-up appointments, does not adhere to prescribed medications without close supervision. Most recently, she swallowed a pen, underwent an initial surgery to remove the pen, and began recovering until she noticed that Dr. L, a second-year surgery resident, came in and she started to yell, "I never want any more surgery ever." Dr. L approached her, sat with her, and explained that she needed at least one more surgery to check for bowel perforation. And in her despair, she yelled out, "No one cares about what I want. My decisions don't matter and have never mattered." So the commentary and the points that the authors point to as, some possibilities for discussion. So iatrogenic harm, I might be pronouncing that wrong. I'm open to that. But it is illness that comes about and is caused by either a diagnosis, a manner or treatment of a physician or clinician, a medical disorder, illness, or injury caused by some type of process of medical treatment. So stigma is something that we know is very prevalent for individuals with severe mental illness. It can be characterized by social marginalization of an individual. It manifests in interpersonal interactions and can be embedded into institutions, policies, or clinical care. It often creates conditions for institutional stigma, often creates the conditions for individual stigma to flourish. In health systems, this stigma can be associated with denial of care, substandard treatment delays. They note even possibly physical or verbal abuse. Clinicians' negative judgments and discriminatory comments or attitudes, and obviously can come through rigid treatment protocols. Stigma can introduce some type of iatrogenic harm to patients with mental illness, is what the authors argue. So while there could be some physical harm, there's also some psychological harm that could be created. Research with people with mental illness, they've often described covert psychological harm due to interactions that they have with individuals within the healthcare system. So negative stereotypes, dismissiveness, overprotective or patronizing attitudes, and even physical distancing. So in order to make meaningful progress in closing health disparities that we know exist for individuals with severe mental illness and achieving health equity, both in physical and we need to be able to address both physical and psychological iatrogenic harm, particularly for patients with most serious mental illness who are already vulnerable. And they bring up two major ethical principles that we really should consider in this kind of a thing. First, do no harm. So we want to make sure that we're protecting patients, that we're making sure that they're safe, they're protecting their lives. And in her case, the case of ST, the emergency surgeries may have very well been very necessary to save her life. Yet the flip side of this is that, to actually complete the surgeries, we had, the clinical team has had to engage in coercive practices. So it describes her as being forcibly anesthetized, having multiple episodes of physical and chemical restraints. It's very possible that she has trauma related to her experience with the healthcare system. Engaging, particularly when there's coercion involved, it can be very traumatizing for patients. She also has a history of untreated mental illness. And it seems like the only time that the team has been able to do something clinically with her is when there was a life-threatening emergency. So her clinicians might perceive her as uncooperative and possibly non-adherent. More likely than not, many clinicians would use the phrase non-compliant. But this is very well might be driven by the history of traumatic events her perception of stigma, and the untreated mental illness. And the interventions that have been intended to help her have also resulted in a pattern of harm due to the repeated disregard for her autonomy that was at the stake of her physical safety. So they suggest to minimize any kind of iatrogenic harm, we should be taking, some major things into consideration. So trauma-informed care, engaging in shared decision-making, utilizing an interprofessional team approach, recognizing and challenging biases and stigma, both personally and within the system, and really putting some intentionality about preventing future harm, even, preventing future life-threatening situations. But once we're through that, we have to protect her life. Now, how do we restore autonomy? So an approach that's grounded within the ethical principles of autonomy is really important to consider for those who particularly have a history of receiving inadequate care. And it's important to remember that we do still have an ethical obligation to a patient's autonomy, even when they've been deemed legally not competent to make their own health decisions. Because at some point there is a legal piece of this, but there's also the ethical piece of this. So at that point, I could find my taskbar. I'd like to open up to a conversation. So